For each delivery, a healthcare professional should anticipate the need for resuscitation by preparing the neonatal resuscitation unit appropriately. The heater is switched to 100% in order to reduce neonatal heat loss and the risk of hypothermia. Next, the following instruments are assembled on the resuscitation unit: a suction device, saturation meter, and an oxygen mask. In order to dry the baby and maintain neonatal temperature, warm towels and a hat are prepared. Suction can be switched on and off using the control panel, as seen here, and it should be first tested by closing off the suction device. The suction pressure may be adjusted as seen here. The oxygen can be switched on and off using the control panel, as seen here. The positive end expiratory pressure and positive pressure ventilation settings are checked. Here the pressure can be adjusted by rotating the dial. The flow rate per minute can be adjusted at the panel. The percentage of oxygen delivered can be adjusted from 21 to 100%. A self-inflating resuscitation bag, also known as an AMBU bag, can also be connected. The light can be controlled by either using this button or the smaller light at the top of the table. Note that the resuscitation table can be adjusted in height using the panels at the bottom of the table. The following materials and instruments are prepared: dry towels and a hat to dry the neonate and maintain temperature, a stethoscope to assess respiratory condition, gauze swabs and a suction device to clear the mouth and airway, and an oxygen mask for preterm and term infants. If the newborn requires life support, it is taken to the newborn resuscitation table. The clock is started in order to time the resuscitation cycle. Time of birth is recorded, as is the APGAR score, at 1, 5, and 10 minutes. In order to maintain neonatal temperature, wet towels are removed. Avoiding neonatal hypothermia is extremely important for the condition of the neonate. Towel drying will often stimulate breathing, as shown here. The newborn is then wrapped in warm, dry towels. The head should be covered with a hat. Aside from drying, a drop in neonatal body temperature may also be prevented using the heater of the resuscitation unit and keeping the panels up. Note that preterm infants of less than 29 weeks gestation or with a very low birth weight for gestational age should be placed directly in a polyethylene wrapper in order to prevent hypothermia. When this is done, the infant is not towel dried beforehand. The condition of the neonate is assessed through skin color, tone, breathing, and heart rate. First the hands, thorax, and mouth are assessed for skin color, looking specifically for cyanosis. Tone is assessed by lifting the forearm, as seen here. Heart rate is measured either by using an oxygen saturation probe, umbilical cord palpation, or auscultation of the heart using a stethoscope. Palpating the umbilical cord is less reliable with a heart rate under 100 beats per minute. Therefore, newborn heart rate is best assessed using a stethoscope. After assessing the skin color, tone, and heart rate of the newborn, breathing is assessed by looking for movements of the thorax, crying, or gasping. If available, newborn oxygen saturation should be monitored. A saturation monitor applied to the right hand or wrist can give an accurate reading of both heart rate and oxygen saturation. Heart rate and breathing are measured every 30 seconds until resuscitation is no longer needed. The healthcare professional may call for help at any time during a resuscitation, and it is imperative to do so when required. If the heart rate is greater than 100 beats per minute, no intervention is required. If the heart rate is below 100 beats per minute, or when the newborn is gasping, an open airway should be ensured and the lungs should be inflated. This is shown in steps 4 and 5. To facilitate adequate breathing, the newborn's airway must be open. A closed or obstructed airway may be a result of the position of the newborn's head, a jaw with low tone, or direct mechanical obstruction. If the newborn is not breathing adequately, or at all, the following steps are performed. The newborn is placed in a supine position with the head in the neutral position. This means the neck should be neither extended flexed or rotated. A prominent neonatal occiput directly after delivery may prevent sufficient extension of the neck, causing airway obstruction. Elevating the upper back, such as with a rolled-up towel, allows the neck to extend sufficiently in order to obtain a neutral head position and an open airway. In newborns with a reduced tone, chin support may be provided. This is done by placing a finger under the chin and lifting it upwards. If the newborn has absent or very low tone, it may be necessary to perform a jaw thrust to maintain an open airway. With a jaw thrust, the whole jaw is supported by placing the thumbs on the cheekbones of the newborn, with the palms resting on the forehead. The index fingers, and if needed middle fingers, of both hands are placed under angles of the mandible. The lower jaw is then pulled forward, opening the airway. The mouth is checked for obstructions and may be cleaned out using a gauze swab. Visible secretions may be removed using suction. If suction is used, it should not exceed 100 mm of mercury. Note that routine suctioning of the mouth is not advised. This is also the case in the presence of meconium-stained amniotic fluid, with infants who begin breathing on their own. Intubation of the newborn for the provision of a definitive airway will not be demonstrated in this film. If the newborn is not breathing, breathing inadequately or gasping, following thorough stimulation by drying and clearance of the airway, the lungs are inflated by giving 5 inflation breaths. A mask is placed over the mouth and nose, paying close attention to avoid air leakage. To maintain an open airway, continuous chin support is provided using the EC clamp technique. Care is taken not to place the ring finger on the lower jaw, as this may cause airway obstruction by pushing back the tongue base. 5 inflation breaths are given, lasting 2 to 3 seconds each. Inflation breaths are given in order to attempt to force fluid out of the alveoli and replace this with air. If inflation breaths are performed correctly, thoracic movement will be visible, as seen here. It is paramount, therefore, that while inflation breaths are given, the chest is observed closely for movement following each breath. Please note, however, that over the first 1 to 3 breaths, the chest may not be seen to move due to the presence of fluid in the alveoli. In the event that chest expansion is not seen on inflation of the neonatal lungs, the following factors should be considered. Is the airway open? Is the head in a neutral position? Is there an obstruction of the oropharynx or trachea? Is there leakage of air from the face mask seal? Is the inflation time correct, 2 to 3 seconds? The correct ventilator settings for a baby at term is 30 cm H2O. Note that in preterm infants, ventilation pressures should not exceed 20 to 25 cm H2O. During the resuscitation, the condition of the newborn is reassessed every 30 seconds. If chest expansions were not visible, inflation of the neonatal lungs is repeated before moving on to the next step. If chest expansions were visible, the subsequent steps are dependent on the results of the reassessment. If the heart rate is over 100 bpm, with adequate neonatal respiration, then resuscitation is stopped. If the heart rate is below 100 bpm and thoracic movements have been seen, the next step is ventilation of the lungs. This is shown in step 6. After inflating the lungs, it is advised to continue ventilating at a rate of 30 to 40 breaths per minute for 1 second each. In cases of home delivery, a self-inflating bag and blow-off valve set at a 30 to 40 centimeters H2O can be used. The oxygen level is set to 21% and may be increased if necessary. After 30 seconds of ventilations, the condition of the neonate is reassessed. The result of this assessment determines the next step. After 30 seconds of ventilating the lungs, the condition of the newborn is reassessed. If the heart rate is above 100 BPM, no further interventions are required. If the heart rate is between 60 and 100 BPM, ventilations are continued. If the heart rate is below 60 BPM, the healthcare professional starts chest compressions. This is shown in step 7. Chest compressions should only be started when the healthcare professional is sure that the lungs are successfully inflated. Upon commencing chest compressions, the concentration of oxygen delivery is increased to 100%. If necessary, the positive end expiratory pressure, or PEEP, may be increased according to local protocol. If help has not been called for up until this point, it should be done now. To perform chest compressions, the chest is grasped with both hands by placing the thumbs on the lower third of the sternum on the imaginary line between the nipples. The second, third, fourth and fifth fingers are wrapped around the thorax and placed over the spine at the back of the newborn. The chest is compressed firmly and quickly by pushing the sternum downwards, approximately 1/3 of the depth of the thorax. Care must be taken to ensure that the sternum is allowed to rise between compressions, allowing the heart to refill with blood in between each compression. During chest compressions, another healthcare professional needs to take over ventilation of the lungs. Ventilation is performed with chest compressions at a ratio of 3:1. The rate of chest compressions delivered should be between 100 to 120 per minute. In order to keep track, it is advisable to count the compressions out loud. Chest compressions in the newborn attempts to move oxygenated blood into the coronary arteries in order to initiate cardiac recovery. Often, this will be achieved after about 20 to 30 seconds of compressions, before the heart responds with an increase in heart rate. Note that in an outreach or home birth situation, the healthcare professional may be on their own. When this is the case, chest compressions are given with the index and middle finger of the same hand, providing the ventilations. Note how the self-inflating bag is resting on the hand that is holding the breathing mask with the CE clamp technique. After 30 seconds of chest compressions and ventilations, the condition of the neonate is assessed in order to determine the next step. If the heart rate is above 100 beats per minute, the resuscitation is stopped. If the heart rate is between 60 and 100 BPM, chest compressions are stopped and the healthcare professional returns to ventilating the lungs. Ventilating the lungs is shown in step 6. If the heart rate is below 60 BPM, the healthcare professional continues chest compressions. Drugs may be administered by the pediatrician. The neonatal condition is assessed every 30 seconds.